I had just came from another meeting in which some folks were in that meeting with me sitting here, so had the camera pointing awkwardly.
No worries. We're happy you can join us. So I think this is a great time to kick off our webinar for today. Hello, everyone. I'm Wendy Fox-Grage. I'm a senior director here at the National Academy for State Health Policy, and I'm thrilled to welcome everyone to today's webinar about Hawaii's first in the nation Medicaid state plan amendment for community palliative care. Before we get started, just a couple of technical items. If we can have the next slide. Thank you so much. We encourage you to ask questions. And you can do that by clicking on the Q&A function at the bottom of your screen. We're going to make sure we got a little bit of time here at the end so that we can address some of those questions and comments at the end of the webinar today. And the biggest question we always get is, how can we get the slides? And I'm going to tell you beforehand, the slides are amazing. And we're also recording this webinar because we want to make sure that we can post that on our website and make that available as well. So thank you all so much for tuning in and joining us today. I also want to thank the John A. Hartford Foundation for their generous support of this webinar and really all of our work that we have been doing over the years in palliative care. So many thanks to our project officer who you're going to be hearing from very, very soon, who's fantastic, Scott Bain. Next, on the next slide, you'll see our fantastic agenda for today. After Scott gives a welcome and talks a little bit about what palliative care is, you're going to hear from me very briefly about NASHB's involvement with state palliative care and some resources we have that are available. Then we're going to go to our main event, where you're going to hear from Team Hawaii on what this is and how they did it. So we're going to hear from Judy Moore Peterson, who's the Medicaid director of Hawaii. Joy Suarez, who's very, very involved over the years in this. She's a policy analyst there. And then we'll hear from Tori Fields, who worked very closely with this great team in making this a reality. And then, of course, we'll end with the Q&A. Before I pass the baton to Scott, I guess you can see I've been watching the Olympics with the relay races. So before I pass that baton to Scott, I just want to say a big congratulations to the state of Hawaii. They have been working on this for many years now, and it's such an exciting time, and we all look forward to learning from you. I also want to thank the John Hartford Foundation. As I said earlier, they have been in it with us for many years as well, and our work in palliative care, for all of their guidance, leadership, and patience, because it takes a while for these things, right? When we're talking about systems reform and culture change and all of that. So many thanks to them as well. We're really looking forward to hearing and learning from the state of Hawaii. We're constantly looking to identify new innovations like this and best practices, and then to share them with you, to share that information out. And that really is the point of today's webinar, is states learning from states. So with that, Scott, I'm going to pass the baton to you. Here we go.
Thank you so much. I'm Scott Bain. I'm a senior program officer at the John A. Hartford Foundation. And on behalf of my colleagues at the foundation, I want to welcome everyone to today's important session. More is happening in the world of palliative care than at any time in the last 20 years. And as Wendy said, what Hawaii has done with the first in the nation Medicaid state plan amendment for community-based palliative care is something to celebrate and to learn from. So welcome everyone to today's session. Next slide, please. The John A. Hartford Foundation is a private philanthropy. We are based in New York City, and we were established in 1929 by the family owners of the A&P grocery store chain, for those of you who remember A&P. As of March of this year, the foundation has donated $724 million to food care for older adults. Next slide, please. Today, we do that in 3 priority areas: building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. And as you can see from the graphic on this slide, we very much see these 3 areas as overlapping. And next slide, please. So what is palliative? Palliative care is interdisciplinary team-based care that focuses on relief of pain, symptoms, and stresses of serious illness. Importantly, palliative care is not synonymous with just hospice. It can be effective for curable and chronic illnesses, as well as progressive and terminal illnesses. I want to thank Nashby, Torrey Fields, and our guests of honor from Hawaii. We'd all like to do a site visit to Hawaii, I'm sure, but we appreciate the resources that Nashby is making available to states that are interested in learning from Hawaii's example. And with that, Wendy, I will pass the baton back to you to launch into today's program. Thank you.
Fantastic. Thank you so much, Scott. Really appreciate that. Okay, next slide. So this is probably the most important thing I'm going to say, and this is my contact information. So for states that are tuning in today, if you have any questions or if you need any resources, we're always happy to follow up with a conversation. Please give me an email. So you can reach me at wfgrage@nashby.org. So this is who I am. We're always happy to help. Next slide. For those of you who might not be familiar with our organization, we are a nonpartisan, nonprofit organization, and we're all about state health policy. We have offices in both DC and Maine. I'm out of the DC office, and my team has been honored to work on state palliative care policy for the last several years. We have a number of different resources, if we can go to the next slide. And this is just a sample of them. So I encourage you to go to our website. We publish everything. It's nashby.org/palliative-care. Where you can find this. We constantly are tracking state legislation, state budgets, palliative care, advisory councils, information and education, palliative care programs, and even more. Those, we call them 50 state trackers. Those are interactive maps. So you can click on the state and you can find exactly what they have done within a subtopic area of state palliative care. We update those on a regular basis. We also have what we call is our state resource guide. And again, this is on state palliative care policies, connecting patients to palliative care. We know there are lots of workforce issues. We've got information on that as well. And then of course, paying for palliative care. And you're going to be hearing a bit about that today as well. We're constantly publishing briefs that are of interest to states. So this is an example of our latest brief that we just published on state palliative care advisory councils. And we follow what those councils do in their reports and recommendations and work. Because again, we want to let states know from each other and kind of share those best practices. We have a variety of resources, but the most important thing probably on the slide is our palliative care newsletter. We have a newsletter that comes out quarterly where we can keep you up to date on what states are doing in this area. We share resources, we share what is going on and kind of the latest and the greatest. So please sign up for our newsletter. You can also get to the newsletter by, again, going to nashby.org/palliative-care, and we're happy to add you to that as well. Next slide. Okay, and now for the main event. I want to bring on our Hawaii team to talk about community palliative care. On to Hawaii.
Thank you so much. Had to get myself off of mute. It's been a day. So thank you very much. So I'm joined by my able colleagues. I have Joyce Suarez with us today, Tori Fields. Are the slides moving forward? No. Okay, there we go. All right, and so we're all on, and we will each have time to share a little bit about our journey on our way here. But I'm Judy Moore Peterson. I'm the MedQuest Administrator, which is the title for the Medicaid Director here in the state of Hawaii. Next slide, please. So why is it that we're focused on palliative care? Just as a reminder, I know all of you who are on this journey with us and have joined the webinar today, I know you all know this and you already have a pretty strong idea about why are we engaged, why do we think community palliative care is such an important thing. And this kind of summarizes it for us, that we have a fragmented, confusing healthcare system that does not do good things for individuals who are suffering from serious illness. Our healthcare system focuses on body parts, not on the whole person. You even have, physicians and care describing the body parts that or the diseases that they're focused on. And it's not a holistic system. It's not a system and the more things that you have going on with your health and your healthcare, or even your life in general, the more difficult it is and the more challenging it is to get consolidated, coordinated care. So, and if you're thinking about someone with serious illness and having to navigate all the various different systems and have that care so that everybody's talking to each other and is talking to you or talking to each other, it's extremely challenging. Next slide, please. So here's a little bit of that. You already heard a little bit earlier about what palliative care is, and this is from our perspective, some of the basics of the whys and what fors regarding palliative care. Why are we doing this? Why is it important? What kind of care are we looking to put in place? So for individuals with serious illness, we recognize, given that extremely fragmented, broken system, that individuals need extra support from a multidisciplinary team that bridges all the care settings, geographies, and cultures. And individuals with serious illness really need to have that whole-centered, person-centered approach that includes thinking about and addressing and talking about what's needed from an emotional, social, family, spiritual, cultural, and intellectual aspects of care. It's the whole person and really the whole family within that community, et cetera, that an individual who is dealing with serious illness needs to have with them. We also know that individuals need, and their caregivers need, the right care. In other words, not going to the hospital all the time, the emergency room, urgent care. So they need the right care 24/7 at the right time. So it needs to be available at the, for that 24/7 time period, not just during the day, not just during the regular business hours, et cetera. From the right person. That's why that multidisciplinary team becomes so important. And at the right place. Again, not in the hospital if they need the care, and they can provide care in the home, in a different community setting. And it's so critical. I'm going to pause just to see if either Tori or Joy has anything to add on this particular aspect.
No, you did great, Judy. Thanks.
Great, thank you. Next slide. Oh, and Tori, this is your slide.
Hi, everyone. I'm Tori Fields. I had the great opportunity of working with the MedQuest team throughout this journey, and thanks to generous support from the Stupsky Foundation, who really worked collaboratively with us to develop these recommendations over the past few years. One of the questions that we were asked a lot and that we asked ourselves a lot when it comes to developing a palliative care benefit or program is, where does palliative care fit into the continuum of care? And why do you need a separate palliative care services program or benefit when there are already a lot of other programs available to people with serious illness? When we were performing a comprehensive scan of services available, we found that there are many different programs that do some aspects of palliative care services along that continuum of care for a person with serious illness. And the eligibility criteria and services delivered were working to address different treatment goals than what palliative care services are intended to do. As we all know, care coordination for people with serious illness is critically necessary. And we identified a considerable gap in services or access to services that could really only be addressed with a new set or a new bundle of those services that addressed the unique goals that palliative care addresses. And so as you can see, some states have health homes that is an optional benefit that then can leverage an additional tier or an additional component that can be palliative care. And there's also a need to differentiate palliative care services from things like home health or hospice or home and community-based services who might actually serve that same type of a person, but only for a certain part of their continuum. So these are some of the design elements to really think about or consider when putting together a program like this. Next slide.
So, building on a little bit what Tori was noting, you know, when from a Medicaid perspective, when you're thinking about, well, how do we have community palliative care? How should we go about approaching this? What's the best way? And so, we eventually chose the state plan amendment route because we wanted it to be considered as like an actual benefit within the Social Security Act. It's called the 1905 section, 1905A section, which is an outline of where all the Medicaid benefits are. Some of them are regular, some of them are optional, and then some you can only get through a waiver. So some of the things that Tori was covering when it comes to the home and community-based services, you can only do that through getting in a waiver. And then health homes is a different kind of authority, and then hospice is actually and home health are both considered to be 1905, but they had limitations regarding the kinds of services that were available to them. There was this gap area. So for those of you who are not steeped in the world of Medicaid and you know, wonder where the sauna is and when Medicaid programs start talking about spas. So a spa is a state plan amendment. And essentially what a state plan is an agreement that we have, that Medicaid programs have with the federal government that says, here's how we're going to be operating our program. These are the services that we're providing. This is how we're going to make the payments, the payment methodology. Here's the providers. And it's the outlines, the programs, the policies, and it's the operational approach that states are using to administer their main Medicaid program. And so each of the services that are listed in the state plan, they have to be tied to an existing 1905 a service, such as inpatient, outpatient, physician services, hospice, and home health. There was no community palliative care benefit. Community, meaning not in the hospital. So non-hospital palliative care. No such thing existed in the 1905 area. So we needed to create it. And so that's why you find the palliative care dipped in there in this area called a preventive service. It's categorized as a preventive service. And so here's the definition pulled straight from the Social Security Act of preventive services. So other diagnostic, screening, preventive, rehabilitative service, blah, blah, blah. And then the last little sentence is one of the key sentences there: for the maximum reduction of physical or mental disability and restoration of an individual to the best possible functional level. Now, if you're thinking about what palliative care is, it sort of fits into that definition as far as providing, it's providing a multidisciplinary approach to help individuals maintain or improve their health based on providing this palliative care benefit. At least that's how we approached it. Next slide, please. So our estate plan, the other goal with the state plan is to have enough detail, but not too much detail. And so you'll see in our state plan, we have a general description of the services. We include the provider qualifications, the skills needed, the fact that it's a multidisciplinary team. You'll actually see also we included who we thought should be required or optional. States themselves can make different choices there about who they would want to include as being required or optional. But you do have to describe what each team member, what their roles are and the qualifications and skills needed, including this in the state plan section. So that is something that's required. You actually also need to have a payment methodology that's actually also required. It's a bit more to that in a little bit. In our case, the way in which we put it together, only one provider is allowed to receive this bundle payment for the actual provision of the services. And then you will actually also see in our state plan, you will see this preventive services clause that says that this benefit attests that the services meet this 1905A 13C criteria for maximum reduction of physical or mental disability and restoration of individual to the best possible functional level. That's required for it to be in this area. That little clause there, it has to meet that. Otherwise you can't put it there. And we tried lots of different areas. We thought about lots of different ways of where it could go. And in the end, working with CMS, this is the best place that we thought that we could come up with that got us the furthest along to getting the community palliative care to be a regular Medicaid, optional Medicaid regular service that other states could also get. Our state happens to be a fully managed care state, but of course, in a state plan, it's for all delivery systems, including fee-for-service. Being a managed care state, our services will be through the managed care plans, but of course, other states have various different kind of delivery systems that they can use. And then just as a side note here, the rates will be tiered for, and you'll see that I think that's in the state plan as well, but they'll be tiered for Medicaid only or the dual eligibles. In other words, Medicare, Medicaid eligibles, because of the Medicare is primary for some of these services. And we'll publish the fee schedule, and the billing codes will be available on the slides in the reference section when those do get sent out. Next slide, please. And I'm actually going to turn this over to Joy.
Great, thank you. So I'm gonna, in the next few slides, describe the benefit. And so wanted to start out by saying that we try to use as broad language in our state plan amendment as possible to give us the maximum amount of flexibility to make changes. So in our state plan, we said that we, the Medicaid agency, would determine the clinical eligibility criteria. So as a part of that, that means that in the next few months, we as the Medicaid agency are going to issue an implementation memo with a lot of the specific information contained here. So this isn't finalized, but this gives you a flavor of who we were trying to target when it came to receiving the palliative care benefit. So we decided to be prescriptive in this area and provide a lot of detail. And we did so for a number of reasons. One, we wanted to make sure that ultimately all of our managed care plans approved had the same consistency of approving members being able to receive the palliative care benefit. So access was equal across all of our health plans. And the other reason that we're being prescriptive in our memo is because we really want to demonstrate that we want to have the benefit available for those along the continuum of for those that are experiencing serious illnesses. There are some that are in the early stages of their illness, and then there's some that might be in the later stages of illness. We want to make sure that we're definitely taking care of those at the later stage of their illness when they have functional decline. But we also, it was very important to us to really focus on going upstream and making sure that we're also providing services to those that are earlier in their stages of serious illness along with functional decline. And the reason why we're doing that is because we think that palliative care can actually it can help all groups. But in the upstream groups, we believe that there's the potential for maybe even being able to prevent the conditions from getting worse, or at least stabilizing them a lot more. So we believe a lot that palliative care can help with supporting individuals so they're achieving their greatest level of health that they can achieve. And so we divide our eligibility criteria. We talk about it in terms of for adults and children. And then we also have a category for children, because obviously they're different and they have, there are differences when it comes to the clinical criteria. We wanted to make sure that kids were included in this as well. And also just to note, we are going to allow our health plans to have some flexibility in that if there are some conditions that are not specifically listed and they believe that it meets the criteria for serious illness with functional decline, then they are allowed to go ahead and approve those conditions so those members can receive palliative care. So next is talking about what the services are. So, oh, let me see here. Oh, who is this? Let me see. Sorry.
This is for the kids. The kids.
Okay.
Yeah. So you
Oh.
had one with the adults and kids, and this one's the kids.
Sorry. So go ahead. Next slide, please. So next, we're going to talk about what the services are. And so with the services, there's the assessment and the care plan that needs to be done for each individual. There are the clinical services, and that's addressing a person's holistic needs. That includes visits by an interdisciplinary team, access to care 24/7, 365, medication management, etc. And then there's also care coordination and communication. So it's also good to know when you're a state going through this, one of the things that we have done and will do is even further clarify this, in that we feel that we need to set standards for the clinical services. So in our upcoming memo, we will state the frequency, expected frequency of visits that need to happen to our members, so that we know that there's access, that they're actually getting care, and it's consistent across all providers. And so we will be issuing the memo that specifies what needs to happen and the frequency in future future memo. Go ahead in the next slide, please. So as Judy mentioned, we had to focus on determine who the providers would be. So we spent a lot of time with our communities, and what we found is there needs to be a lot of flexibility for providers to be able to build a team based on what their patients' needs are. And so we came up with a standard of having.
Hey, Joy,
Yes.
is the pounding at your location?
I'm
Okay,
sorry.
it's a little hard to hear. I'm wondering, Tori, or Tori, can you cover this one? And then the next one. I'm so sorry, Joy.
Oh, no.
It was a little hard to hear. Yeah, the hazards of webinars.
I think the pounding has stopped for Joy.
Oh, it just started again. Sorry.
Sure, absolutely. So we spent a lot of time with the community to really get a better understanding of what the provider services are that should be required as part of this standard of care. And we leveraged initially these National Consensus Project clinical practice guidelines that identify the base team members who would actually be required to deliver a high standard of palliative care services for the population. As you see here, these are separated out by those who are required and team members who are optional. We want to make a note that for children being included, we wanted to ensure that the level of care for kids was also upheld, and so included a child life specialist as a required member of the team. And this, the state plan amendment goes into more detail related to the training and the competencies that are associated with each one of these members of the care team to really uphold that standard of care. In addition to that core team, the optional team members can really help to extend those core members, knowing that there are a lot of resource constraints that often occur in rural areas and even in urban areas, and that not everybody is going to need say, access to a pharmacist ongoing in certain teams. So we wanted to make sure that there was a level of specificity that upheld the standard, but also a level of flexibility that enabled care teams to deliver care to a wide range of people.
Tori, I think the other thing just to pull out here is, for example, you'll notice that like a nurse practitioner or an advanced, practice RN, depending on, in some states, they have more or less, a criteria and scope. And so based on our scope, this is how we oriented it. And the other, for example, you'll see the mental health professional, the community health worker. So your state may make choices to pull some of those over from the required side, from the optional side over to the required side. And just noting that. And then the grief counselor, the other thing I wanted to note about that is we had incorporated a spiritual care provider like what they have in hospice, but that was in the end not allowed. And so the grief counselor is the closest we came to that as a possibility.
Great call outs.
And I would say too, what we added in terms of the grief counselor is that they're allowed to, their credentials for it, they're allowed to have a bachelor in theology. So that allows some flexibility to be able to have potentially a chaplain providing the grief counseling services.
I think it's the next slide. Joy, can you take?
Sure, I'll take it, and hopefully the neighbors will stop pounding. So how's this paid for? So essentially, we pay for the assessment, and separately, we pay for a reassessment, and we require reassessments on a regular basis to ensure that our members are still meeting the clinical criteria, and they're also being assessed to see if they have other needs. And then all the other services will be paid with a bundled payment. So that's a per member per month payment to the billing organization. And they are allowed to pay their staff and as they see fit. So it's important to note that the bundled payment in our upcoming memo, we are going to put forward standards of what they need to do in order to receive the bundled payment. So they can't just receive the bundled payment month after month without doing any services. So we clarify that in our future upcoming memo to ensure that our members are getting access to good quality care. And as Judy mentioned, we are tiering it. So a higher payment will go for patients that have just Medicare, and a slightly lower payment for those that members that are dual eligibles that have Medicare and Medicaid. And we had a lot of discussion about additional tiers. We chose not to do this from the beginning because we need to kind of test this out, figure this out before and try and make things as simple as possible. But we have talked about maybe in the future having additional tiers, meaning that for those providers that provide services to those that are houseless, that have serious behavioral health issues, or have a lot of social risk factors, we may in the future provide a tiered payment where they will receive a higher amount for caring for specific members, as I mentioned. Next slide, please.
All right. So as was already mentioned, we are in the process of issuing a guidance memo on the implementation, in which a lot more details will be included. We'll have a draft review by our stakeholders that includes, community members, palliative care providers, our health plans. We'll be issuing that in the third quarter of 2024. We'll get feedback and review and go through our normal process of back and forth to refine it. And we hope to issue this in the fourth quarter of 2024. So by the end of the year is our target for being able to put this out. And then although we're not required to do an evaluation, we think we're in a habit of doing evaluation because of we have an 1115 waiver in which we're always doing evaluations and monitoring. And we think it's a super great idea that we do this. We're moving out there. We want to be able to collect the data, monitor and perform rapid cycle evaluation also, so we can make improvements as we're moving along. If we have to change something, modify something, add additional tiers, change the clinical criteria, that's all part of what we hope to do. And then also just see how it's being accepted, whether our communication methods are working, et cetera. We have some workforce development and some communication messaging that's also happening. MedQuest, we contracted with a group here called Hui Pahala to help prepare the workforce and develop communication, messaging, and education. They do have a website and some links, so they are a great resource for others, not just in our own state, but actually for others across the country. And then on the communication, messaging, education front, I mentioned another group, Kokua Mau, that also has some great, and they're part of the Hui Pahala group as well, but they have some additional resources on their site as well for both professionals as well as for members and individuals with serious illness to learn about what palliative care is. Next slide.
So we wanted to end this conversation or presentation with some considerations, common opportunities and pitfalls to consider as part of this process. These considerations really can help to ensure the highest degree of success, both in developing a benefit that's representative of the community, that can be filed and approved through this process with CMS, and in the implementation process, which can be difficult for new programs or new benefits that become available. Some of the key highlights include using evidence and experience from publications and programs that have gone before. This project really benefited from private payers who had tested out a palliative and supportive care benefit that was available to the community and to the population that we could really learn from. And we also learned from specialty palliative care providers and organizations that are really upholding and maintaining quality standards of care, like the Center to Advance Palliative Care and the National Coalition for Hospice and Palliative Care, who've really put forward guidelines for the country that we could leverage for this process. We also really worked collaboratively with stakeholders across the entire community to ensure that when we're talking about health equity, we're not only talking about it when we're thinking of the services or the team that's being delivered, but really embedding health equity into the entire design process and into the implementation process. So thinking about messaging, thinking about what are the qualifications of care teams so that they can be culturally congruent for a diverse population and can really meet the needs of Medicaid recipients. When you're working so closely with stakeholders, it's natural that barriers and challenges arise that need to be resolved. And we focused on resolving those barriers in a way that was whole person oriented and addressed multiple stakeholders' needs in the most equitable way possible. So some of those barriers we had to work through included how flexible or specific to be in eligibility criteria or in screening tools or team members and their training and competencies. And we also had to consider things like duplication and differentiation of services along the care continuum, and to work to define which provider organizations or agencies would be able to gain access to reimbursement like this. In addition to that, we looked at the structure and feasibility of reimbursement that would compensate all members of the care team in a longitudinal way, and that was limited to those specialty palliative care teams that we would feel confident could uphold the standard of care that we really all want for people with serious illness and for their families. So these are the design considerations and some of the challenges that you might face when developing a program like this. And as you've heard and what you'll see in the implementation memo are really the decisions or the ways that we resolved these through the stakeholder engagement process. Next slide.
All right.
right.
Thank you
Yeah,
so much. That was fantastic. Okay, we are getting in lots of questions. So I'm going to try to group some of these questions and we're going to try to get through as many as we can. So I think the first question and the last question we received, let's ask those together. So if a patient is already receiving home and community-based services, will they also be eligible to receive community palliative care services, or is that double dipping? Do they have to choose?
No, they don't have to choose. So as long as they meet the clinical eligibility criteria, anyone on Medicaid can receive community palliative care. So it's the clinical criteria eligibility that determines whether or not they receive the services.
Because it's a different set of services. Yeah.
The only component here in terms of thinking about the continuum of care is that is in thinking about hospice care, which is separate, where if somebody is receiving hospice care services, the palliative care is included as part of that hospice benefit. So HCBS is separate, home health is separate. Those things can be sort of layered in, but hospice, we would expect that somebody would disengage, stop using the palliative care benefit in the same way that they would, stop using their other benefits.
And then what about for Medicaid members who either live in a residential care home or a foster care home? Would palliative care be paid for? And then, is that service paid for in addition to the cost of care in those types of settings?
It's the same type of question. So the services and the payments are that because the care is different and palliative care is different, an individual can be residing in a adult foster home or adult residential care home or a nursing facility and receive these services. It's a bit different than the hospice situation in that if you're in hospice, you can be in a nursing facility. You can actually also receive hospice living in a residential care facility. But the way that hospice works and in a nursing facility is that they make the hospice pay for the nursing facility. With palliative care, it's different because the bundled payment doesn't duplicate services that the nursing facility or the home and community-based setting are providing. The care home and the nursing facility staff will naturally be part of that team, be part of the group that are and not part of the team, they're not getting the payment, but they're going to be in that coordination group, right? Like, what's the care plan for this person? What do they want? What kind of life, what kind of activities do we need to work on in the conversations with the family? But the payments and the team are essentially differentiated.
And then we got a number of different questions about the team and organizations that can provide these kinds of services. So for example, we have a question, can it be a licensed social worker? And I know that's going to all vary, but vary state by state, right? Versus an LCW, SW. But then, Jonathan Cotter has asked, okay, so what organizations do these team members need to be with? Home health, hospice, hospital, and can there be a new type of provider organization open, for example, like a pediatric palliative care licensed home?
Yeah.
The answer is yes.
Okay. Excellent. Perfect.
All of that, yes.
Yes to all.
Yeah, so far the answer has been yes to everything. So that's great. Okay, and I think
one of the things just to note about the social worker piece, because this was something that was really interesting to me going through this process and learning from community stakeholders, is that depending on the level of behavioral health need or coexistence in your population is really going to make a difference between whether this is an MSW or an LCSW or another type of qualifying mental health practitioner. So this is the Medicaid population. We heard from a lot of stakeholders in Hawaii through this process that there was a need to include mental health support as part of those palliative care services as an integrated part. Whereas if you're in a state that has lower rates of psychosocial or behavioral health in your population, that may just be a different choice that you make as a team member. Here it was an important part to include as part of that core team.
Fantastic. Okay, now let's get to payment issues, because I know this is a biggie, and Judy, you had mentioned, you're working with duals in this as well. So
Mhm.
this is a Medicare question versus a Medicaid, and that is, how have you been able to maintain separation with other payers such as Medicare? And it says, the Medicare CCM benefit, it seems to cover similar services. Can you talk a little bit, and Corey, I know we've worked with other states that have had that issue about Medicare, Medicaid, and especially making sure these services are accessible for people who are both dually eligible for both Medicare and Medicaid.
Well, I'm not the right person, so,
Okay.
so sorry.
Tori, you want to take that one?
Or when you're thinking about this is a Medicaid presentation. So what we needed to consider was really looking at how we make the services the same, or the services at a very similar standard for people across the board, regardless of whether they were Medicaid only or dually eligible. And so, it was a design choice to include as part of that application the dually eligible members as part of those who are eligible for services. In terms of thinking about the Medicare side of the house, though, there are benefits and programs that can look or seem a lot like palliative care for the Medicare population. What I would do is really consider looking at and developing a gaps analysis very similar to what we displayed earlier, and to make sure that the treatment goals, the eligibility criteria, and the bundle of services really are the same between both programs. And so the example of the chronic care management benefit, it is something similar to health homes on the Medicaid side, where the CCM model is a lot more similar to a health home model for Medicare than it is for palliative care, which means you may be leaving certain people out or certain services out for the seriously ill population that you're really trying to connect with. So it's really important to sort of match the model with the person, with their needs, to ensure that the coverage across the continuum of care is happening.
Fantastic. Thanks so much. Okay, so now we've got a question about total cost of care for patients. And we get this actually from other states as well. And so the question is, are you able to elaborate on what you expect in terms of impact to the total cost of care for patients with serious illness who are covered by Medicaid?
Eventually, we're, as I mentioned, we're in a managed care environment. And so we eventually expect to see cost savings because of the work that's already been done here, demonstrated that individuals with serious illness tend to go to the hospital less frequently, the ED less frequently, and that offset any additional costs on the care coordination side. We chose not to make a reduction in the capitation rates to start off with to account for that reduction in cost, but we will be evaluating that on a going forward basis. Tori's done a lot of work in this particular area and can speak to that in greater depth. But from a high level, we actually are not expecting a cost increase. We're expecting a cost reduction eventually.
California under SB 1004 has demonstrated those cost savings going forward. One of the things that we really, as Judy was saying, we wanted to be aware of is that it can take a little bit of time for engagement and utilization of a palliative care benefit or any new program to demonstrate optimal results. And so in California, there has been a long ramp of utilization of palliative care services as more and more people become aware of the availability of these services. And so that's something to just include in your cost savings calculations, is who would you expect to actually utilize the benefit to begin with? And then what does an optimal benefit really look like, so that you can get a more accurate assumption or prediction about what the cost decreases look like or the savings look like over time.
Thanks so much. Okay, so we got an eligibility question. Who defines whether a patient qualifies for these palliative care services? So for example, chronic or complex care, which could be a large group of people. If you're talking about children, for example, not expected to live in adulthood, would that qualify? Would that eligibility criteria be met for this new preventive service?
So we are going to issue our clinical criteria and also the evidence of functional decline, what level they need to meet. So it provides a lot of clarity for that, because that's a good question. So we anticipate what will happen is they'll do an assessment to figure out where the member is. And then if they do meet the clinical criteria, then they'll probably submit a request to the managed care organization for approval to begin palliative care services.
And that assessment can be done by a provider, is that correct?
Yes.
Yeah, healthcare provider, yeah. And then the question, if the question was actually also about, I think this is getting to the confusion around preventive services, which is the tricky part. A person can have a diagnosis that is life limiting. In other words, we don't expect that child to live into adulthood. That child could actually also receive hospice services if they are a child. But let's talk about an adult. Let's talk about an adult who has a serious illness, who even with treatment, well, we all die, but within a a short period of time, the difference with the palliative care benefit is that that doesn't matter. It doesn't matter. There is no limit that says, unlike a hospice benefit that says you have to be determined to have less than 6 months to live in order to avail yourself of the hospice benefit, and you also have to give up on any curative care. And that actually led to many people not partaking in the hospice benefit. The palliative care benefit is part of that gap in that overall continuum, in that I could have a diagnosis that means that I am expected to pass away in the next year or so, but I can partake in palliative care, and I can receive those services, etc. And it is still classified as a preventive services. I'm not expected to get better necessarily. So that is, it is not, one should not confuse either end of it. I don't have to die in order from my serious illness, nor do I have to die within 6 months of the serious illness to be able to receive community palliative care.
I cannot thank you all enough. You did it. To cover this ground in a short period of time. And those were tough questions, really tough questions. So thank you for that. For people listening, we also have a fantastic blog. We were able to, as soon as it happened, we were able to interview Joy and Judy. There's a fantastic blog that's on our website if you want to learn more. With that, what I want to do is thank once again Scott and his whole team at the John A. Hartford Foundation for making this webinar possible, and quite frankly, all the work in palliative care that NASHB does on this. We're always so thrilled to be able to put events on like this and to highlight when we've got a major breakthrough and an innovation that we know states are very interested in learning about. We also want to encourage everyone to fill out the webinar evaluation that helps us to continue to improve what we do. So please fill that out. You will get that right after this webinar. And once again, we will be posting the slides and the webinar recording so that you can pass that along to your colleagues if they weren't able to make it today. And with that, I want to thank you all so very much. Thanks again to Team Hawaii and congratulations. Thank you so much to the John A. Hartford Foundation, and thanks to all for attending our webinar today. Bye-bye, everyone.